Thanks to Dr. Bick and the StarMed team for inviting me to be part of this webinar today. It's quite an honor. And as stated, I'm from Columbia University in the great city of New York. I thought we were supposed to present a little bit about our institutional experiences. So we started our program just last summer. Actually, this time last year, I was returning from Seoul after spending a week with Dr. Bick and the hands-on course in Seoul. We did our first case series of patients on August 30th and have subsequently done patients every other week or so. Up until March 16th, when we essentially shut down for the COVID pandemic. But over that interval of time, we did 21 patients, median age 46. You can see a wide range in years, mostly women, and solitary nodule is really the most common indication for patients. I've done a few patients with multiple nodules, 2 of which were toxic multinodular goiters. And I think on average, the nodules that we're seeing here in the US are a larger size and volume, maybe compared to Asia. My median nodule diameter is 3.9 centimeters up to 64. And again, the volume is on the larger side as well. The smaller nodule volumes are really the toxic nodules. The case that I'm going to present today is actually my very, very first case that I did, which was a 37-year-old woman who presented with a single left nodule that was minimally symptomatic, had been biopsied several times and proven to be benign. But since she was euthyroid and again, minimally symptomatic, she was not enthused at the prospect of surgery. And so RFA seemed to be a good alternative for her. These are representative pre-ablation images, both on the sagittal view and transverse view. You can see that it's isoechoic, solid, well circumscribed, ATA, low risk nodule. Looking at the transverse views from superior lobe to mid to lower, you can see that she did have the superior medial vascular feeding vessel here that I did target first per Dr. Bake's teachings, and then proceeded to ablate the rest of her parenchyma. This is a post-ablation sagittal view. So you can see that it shows the very typical post-ablation hypoechoic changes. I think I'm a little different in that I start in the superior pole first and work my way down. So the inferior pole is much more hypoechogenic than the superior pole. But you can see from the transverse views that superior, again, mid to inferior, that I thought I had pretty nicely ablated the superior medial feeding vessel. And we had estimated at the time that we had covered about 90 to 95% of this thyroid nodule. So I was very pleased with my very first case. Pat myself on the back. And then saw these images when I saw her at 1 month follow-up, and initially was very confounded by what I was seeing. So a sagittal view and then transverse view. In the superior pole, I could see the classic hypoechoic changes that you would expect after RFA. But I was a little confused by this portion here in the inferior pole, which was nice and solid and isoechoic and looked very much like her nodule did before ablation. After thinking about it a little bit more, I suspected it was marginal regrowth of that inferior pole, and I emailed Dr. Bake these images, and he confirmed that it was in fact marginal regrowth, and that I'd likely have to do a second ablation procedure. However, her overall nodule size had decreased in that 1 month, 18.8%, and was her volume reduction ratio. So I decided to keep watching and see how this nodule was evolving, especially since she really wasn't symptomatic. This is just assessing the vascular supply at 1 month from transverse views. You can see she's got a nice supply superiorly. This superior medial vessel is already starting to reconstitute, and she had quite a bit of flow inferiorly as well. At 3 months, this is what her nodule looked like. The superior portion that was nicely ablated continued to shrink, but we're starting to see a little bit more predominance of the solid inferior portion. Her volume reduction ratio at this time was 50.7%, so we were still happy with this. And I had kind of set for myself the 6-month mark to reassess for the re-ablation procedure. And this is what her vascular supply looked like at 3 months. So you can see superiorly, the flow from that teeny tiny superior pole vessel came through and was feeding what I had previously ablated in the superior medial aspect of the nodule. And then inferiorly, although I couldn't capture it well, this vessel here was actually a very dominant feeding vessel to this inferior portion. Then I followed her at 6 months. And although we had seen a nice decrease in her volume, a nodule volume up to 3 months, by 6 months, the curve had changed. And so I actually had her on the schedule for a second ablation procedure that then got deferred by COVID, and we haven't had a chance to do that yet. But this case really has sort of bothered me ever since I saw those 1 month ultrasound images, and kind of thinking about it, 2020 hindsight in the year 2020, trying to think of ways that I could have mitigated the robust nature of this marginal regrowth. I realized that I likely failed to address adequately the superior and inferior feeding vessels. So if you look at this original sagittal view of the ultrasound, the vessel that I ablated was here, but she does have this very tiny vessel coming in superiorly that I likely did not address appropriately. And I actually did not capture the inferior pole of this nodule. And it's not because it didn't fit on the probe, because obviously I had more space here, but it was likely hidden underneath her clavicle. And that also precluded me from seeing that inferior feeding vessel to the lower pole as well. And so if you transpose this on what she looked like on the table, her nodule likely had a portion that sat inferior to her clavicle. And if she was in full cervical extension the whole time of the procedure, I probably would have realized that, but she wasn't. And so if you think about the projection of my electrode that I aligned nicely to ablate that superior medial vessel, that would have allowed me to ablate a decent portion of that nodule, but I would have left this inferior portion. And that, combined with the feeding vessel that was hidden underneath, probably was a huge contributor to her marginal regrowth. What I learned from this, and what I've used on subsequent patients with larger nodules, is not to limit myself to actually just the one entry site, and to actually use a second entry site, especially those that kind of have nodules hiding a little bit underneath the clavicle. And this has helped me achieve a greater ablation of the nodules. And so some discussion points for the rest of the panelists here that I'd be interested in hearing your thoughts is, what strategies do you have to effectively ablate these feeding vessels? The ones that come in medially and you're doing the transisthmic approach seem to be much more straightforward, but the two that seem to contribute to the problem in this particular case came into the nodule sort of perpendicularly and not really surrounded by parenchyma to buffer. And then when do you guys re-ablate? What's the optimal timing for that? Initially I'd set 6 months as my reassessment rate and redo rate, but then now seeing that the curve has now turned upwards, I almost feel like I'm behind the game a little bit, especially with the COVID deferment. So when do you guys reassess, and when do you do that second ablation procedure if you know it's going to happen, to really optimize outcomes?
Thank you very much, Dr. Gore. So she introduced how to ablate the solid large thyroid nodule and during follow-up period, she experienced regrowth of the nodule margin. And this issue is very important and now hot topic of ongoing research. Thank you very much. So are there any questions or comments from the speaker, floor?
I had one comment, Professor Bake, maybe you can tell me if I'm wrong. I feel that we haven't had nodule regrowth and we've been doing it almost 2 years. We've been lucky. I'm pretty sure I'm going to get into the same situation as the professor from Columbia. But my question was, I feel that because the heat sink effect with these vessels, the power should be increased when you are ablating the artery and vein, like maybe go up to 55 watts power. Do you feel that that is a reasonable strategy to prevent heat sink and do appropriate ablation of the artery and vein?
Dr. Gore?
I did actually increase power on this particular nodule. I think the parenchyma we used about 40 watts, but for that superior medial vessel, I used about 55 to 60. So we did increase the power for that. I think, I was limited a little bit because we were close to the nerve to inferior, that inferior aspect of the vessel. But I think it was more actually reconstitution of flow from those two other vessels, superiorly and inferiorly.
One question from the floor is, if there is a feeding vessel close to laryngeal lobe, would you do hydrodissection and ablate, or you just leave it? Dr. Ko or other speakers?
So I didn't use hydrodissection in this case because it was my very first case. I've subsequently used the technique for when I ablated a metastatic lymph node in the thyroid bed, and it worked well for that. But I didn't use it for this particular case.